For this anatomy series, we are going to add this session on the inguinal canal. In this session, we are going to describe the boundaries and contents of the inguinal canal with a hint on the inguinal hernia. So, that inguinal canal, the passage for the spermatic cord in the male or the round ligament of the uterus in the female. It is a four-sided canal of 1.5 inches in length. It runs obliquely downwards and medially from the deep ring, which is situated 1/2 inch above the midpoint of the inguinal ligament, to the superficial inguinal ring, an opening in the external oblique aponeurosis, which lies above and lateral to the pubic tubercle. Walls of that canal are anterior wall, which is formed in the whole length by the external oblique aponeurosis, this part here, and in the lateral half, the arching fibers of the internal oblique, that is the anterior wall. That is the anterior oblique here. The posterior wall is formed in the whole length by the fascia transversalis, that part which appears here, and medial half by the conjoint tendon, this part over here, and in the medial 1/4, it is by the reflected ligament. Here we'll see an illustration of a cadaveric appearance of the anterior wall of the inguinal canal with some sketches or diagram to show that anterior wall. The whole length, as we said, the external oblique aponeurosis, which appear in front of you here, and that is the superficial inguinal ring where the spermatic cord is coming out from that aperture. So that is the external oblique. In that diagram, it shows the external oblique here, and as I said, that's the superficial ring. Here, the lateral half, as we said, by the arching fibers of the internal oblique, shows in that diagram better where the internal oblique is arching over the spermatic cord. Last, which is when you remove both the external oblique and the internal oblique fibers, now the cord will be exposed completely and the inguinal canal is opened in front of you as it appears in that diagram here. That is the conjoint tendon reflected, and that is the spermatic cord totally exposed here in that diagram. That is the anterior wall of the inguinal canal. The roof of the canal is formed by the arching fibers of the internal oblique, which is assisted by some fibers of the transverse abdominis. This is the internal oblique over here, and over here is assisted by those of the transverse abdominis. The floor is formed in the whole length by the inguinal ligament, in the medial half by the lacunar ligament, which is a reflection from the medial end of the inguinal ligament. Now, that is a cadaveric appearance of the inguinal canal in a male. That is the superficial ring over here, which is an aperture in the external oblique aponeurosis. That is the spermatic cord coming out here, and over here in a dissected inguinal canal, where you can see the external oblique aponeurosis reflected here. That is the reflected part of the external oblique here to show the canal. And you can see within the contents of the canal, the ilioinguinal nerve here. And you can see the ductus difference or the vas difference within the spermatic cord going down to the scrotum. Also, you can see the cremasteric muscle and fascia, which is the second layer of the covering of the spermatic cord. You can see the internal oblique here. While approaching the inguinal canal, you can see the cut edge of the conjoint tendon, the fusion of the transverse abdominis and the internal oblique. That is the ductus difference, as we said. And this is the inguinal ligament from here and from here. That is the inguinal ligament. That is male inguinal canal. Here is a female one, which you can see smaller in size. The contents are less than that in the male. That's why it is smaller. The size is small. That is the upper surface of the inguinal ligament where the external oblique is reflected. The external oblique aponeurosis here and here. That is the internal oblique. That is the ilioinguinal nerve again. That is the conjoint tendon, the edge of it. That is the round ligament of the uterus, the main content of that female inguinal canal. About the main contents of the canal, we have the spermatic cord, which you have seen, or round ligament of uterus in the female, you have seen it, the ilioinguinal nerve, the cremasteric artery branch of the inferior gastric artery, and the gentle branch of the genitofemoral, which is going to supply the cremasteric muscle. Structures of the spermatic cord itself, which is one of the contents in the male, formation of the vas deferens, the artery of vas deferens, which is a branch from the internal iliac through the inferior vesical artery, testicular artery branch directly coming from the aorta at the level of the third lumbar vertebra, the piriform plexus of veins which surround the whole spermatic cord from the testis up, and then within the canal it's almost 3 or 4 veins at the superficial ring. Then at the deep ring, 1 or 2. On the left side, it will go to the left renal vein. On the right side, it will go to the inferior vena cava. Nerves of the testis are derived from those around the aorta and from the segments number 10 and 11 thoracic segments, and they join or accompany the testicular vessels. The lymphatic of the testis will terminate directly upwards in the abdominal cavity on the side and front of the aorta, the pre and the para-aortic lymph nodes. And lastly, the vestige of the processus vaginalis, which has a protrusion from the peritoneal cavity, as we will see. Now, that's a diagram showing the testis coming out from the abdominal cavity with all of its derivatives, the artery, the vein, the nerve, and the lymphatics. So that is the inferior vena cava here, that is the abdominal aorta, that is the right testicular vein which ends in the inferior vena cava, the left renal vein which receives the left testicular vein. This is the testicular artery coming directly from the aorta on each side, surrounded by the sympathetic plexus. The para-aortic lymph nodes and the pre-aortic lymph nodes, which receive the lymphatics coming from the testis. And this is the testis here. That is the aortic plexus of sympathetics. So all the derivatives of the testis comes directly from the abdominal cavity. That's why the internists usually consider the scrotum as a part of the abdominal cavity during examination of the body. This is a diagram showing the processus vaginalis stages. In the first stage, which almost in the third month, it's just a tubular tube coming from the main peritoneal sac down toward the scrotum, with the testis, which is almost at the renal angle. The second, that is the processus. The second stage here, which is almost around the 8 months, the testis is almost the deep ring. The processus vaginalis fill the whole cavity of the scrotum, but still connected to the peritoneal cavity, so that if the testis at the deep ring. The third stage, which is almost around first, the testis is completely down in the scrotum. The processus vaginalis is still connected to the peritoneal cavity, leaving apart or surrounding now the testis here. last stage here, which is shortly after birth, you can see the testis surrounded by a part of the processus vaginalis, which we call it the tunica vaginalis, and this is the vestige, a fibrous band, which is the collapsed processus vaginalis here. We call it the vestige of processus vaginalis. That is the stages of that tubular peritoneal recess. Now we are going to describe the covering of the cord, of the spermatic cord, which is derived from three main sources. First, this is the deep membranous layer of the anteabdominal wall, which will continue in the wall of the scrotum at the darts muscle. The first layer of the spermatic cord covering comes from the external oblique, which we call it the external spermatic fascia. The second layer comes from the internal oblique, which is the fibers of the cremasteric muscle connect together by fascia, or the cremasteric muscle and fascia. That is the transverse abdominis, which give no extension to the spermatic cord. Here is the fascia transversalis, which will give the last one, which is the internal spermatic fascia around the spermatic cord. And this is the tunica vaginalis, part which is left from the processus vaginalis. That is the parietal layer of the peritoneum, which now continues with that vestige of processus vaginalis. So the covering are the interspermatic fascia from the fascia transversalis, the cremasteric muscle and the fascia from the internal oblique, and the external spermatic fascia from the external oblique. The inguinal region is the weakest part of the anterior abdominal wall because the external oblique is the only muscle which extends from the middle line to the lateral side, while the internal oblique will be found only in the lateral half, and the transverse abdominis will be found in the lateral 1/3. So there is some factors which support that region. This factor is the obliquity of the canal itself, which position of the two rings are away from each other, and this help in resisting the pressure. The second, the posterior wall is strengthened by the conjoint tendon and the reflected ligament medially. The internal oblique muscle will support the deep ring anteriorly, while the reflected ligament will support the superficial ring posteriorly on the medial side. But the most important part of supporting the inguinal region is the fibers of the internal oblique, which arch around the canal, having a triple relation to it, anterior, superior, and posterior. And this will perform what we call the shutter mechanism. And this will close the canal against the increased intra-abdominal pressure or the muscle contract. Now, let's have a brief idea about the inguinal hernia. Definition of a hernia: any structure through an opening, passing through an opening, or protruding through an opening of a cavity which normally does not traverse that part is called a hernia, or in other way, protrusion of one of the contents of a cavity through a weak point in the walls of such a cavity. That is a hernia. Inguinal hernia through the inguinal region, brain hernia, a fractured skull, and so on, in any place where the contents of the cavity comes out of that cavity through a weak point. That is the definition. Types of the inguinal hernia usually are congenital or acquired. Congenital usually divided into a complete and incomplete types, while the acquired are divided into weak acquired hernia and direct hernia. This is the general classification of those hernias. But the points to be covered for any hernia when you're discussing a hernia, you should know the type, the line of descent, the line of reduction, the coverings, and to differentiate between that hernia and other hernias. So, classification here, the congenital hernia present since birth, while the acquired hernia in the adults. Congenital is two types, as we said: complete congenital hernia, which occupy the whole length of a persistent processus vaginalis. And in this case, in the field of surgery, the testis will appear, while the incomplete congenital hernia occupy the upper part, leaving the lower part for the testis as tunica vaginalis. And the testis will not appear in the field of surgery. While the hernia in the adults, we said oblique or direct or indirect, which pass through the deep ring. Most of those hernias are due to the presence of variable lengths of patent processus vaginalis, as supposed or uh, described like that. Usually passes through the superficial ring. So a ring going through a deep ring, a hernia going through the deep ring will go or can go through the superficial ring. It is more common in males than in females because we have seen the male duct larger than the female one. Another type of the acquired is the direct hernia, does not pass through the deep ring but totally through the posterior wall of the canal. That's why it's very rarely to reach the scrotum because it does not pass through superficial ring. Usually divided into two types: the lateral one, which is lateral to the medial ligament, medial umbilical ligament, which represent the obliterated umbilical artery through what we call it the medial inguinal fossa. And the medial one is medial to that ligament through what's called supravesical fossa, medial to the other fossa. That is the general, again, classification of these hernias. Now, the main differences between the oblique hernia and the direct hernia: the oblique hernia occurs in young age, while in direct hernia occurs in old age. The oblique hernia have to pass through the deep ring, so it will have a resistance, while in old age, the posterior wall, there is no resistance, which is very weak. Because of that resistance, usually the oblique hernia is unilateral, and because the posterior wall on both sides are weak, so it is bilateral usually. The neck is lateral to the inferior epigastric artery of the oblique, while it is medial to that artery in the direct hernia. And that's a very important differentiation during surgery, which is which in relation to the inferior epigastric. One passed through the deep ring, but that one, as we said, passed through the posterior wall of the canal. Usually reaches the scrotum. Very rarely reach the scrotum. We said which deep pass in the deep with the deep ring, or then the deep ring can pass through the superficial. That one which does not pass through the deep ring will not pass through the superficial one. The deep inguinal ring test for the oblique hernia, the hernia will not appear. We'll know what is the deep inguinal rest ring test soon. And in the direct hernia, it appears, the hernia appears. Other tests, superficial ring tests, the hernia will to the tip of your finger, while in the direct hernia, touches the back of the finger. Now, the oblique hernia, the neck is narrow and is liable to be obstructed or strangulated, while here the neck is wide, so there is very rare to be strangulated, except if it passes through the strong conjoined tendon on the medial side. Line of descent of that oblique hernia is downwards, forwards, medially, while in the direct hernia is directly forwards. The line of reduction of the oblique will be upwards, lateral, and backwards, but for the direct will be directly backwards. The coverings of the hernia here, which is contained in a peritoneal sac called the hernial sac, will be the extraperitoneal fatty tissue, the three layers of the covering of the cord, which is spermatic fascia, spermatic muscle and fascia, external spermatic fascia, the two layers superficial fascia, and the skin. The direct hernia, the covering for the lateral one will be the extraperitoneal fatty tissue, fascia transversalis, spermatic muscle and fascia, the external spermatic fascia, the two layers superficial fascia and skin. For the medial hernia, the conjoined tendon will replace the cremasteric muscle and fascia in the covering. Now, superficial inguinal ring test, you will reduce the hernia, identify the superficial ring which is above and lateral to the pubic tubercle, introduce your little finger through the ring, and when you found it wide, this will be mostly an oblique hernia. Now ask the patient to cough. If it touches the tip of the finger, it is oblique, while if it touches the back of the finger, this will be direct. The deep ring again reduce the hernia. Define the position of the deep ring at the midpoint of inguinal ligament. Close the deep ring by your thumb. Ask the patient to cough. The hernia will come out. It is not coming from the ring, so it is direct. It does not come, this will mean that it is an oblique hernia. The types of hernia are umbilical hernia. There are three varieties of that hernia, which are congenital, present at birth, and usually is due to the failure of retraction of the mid-gut loop back to the abdominal cavity. Infantile, which is due to the stretch of the scar tissue in the umbilical region, and this occurs within the first 3 years of age. And lastly, the acquired one, which is almost para-umbilical hernia, which occurs in the linea alba above the umbilical region or above the umbilicus, and usually in the fat women. Layer hernias like the lumbar through the lumbar triangle, obturator through the obturator foramen, squrectal through the squrectal fossa, and incisional following abdominal operations. That's all about the hernia. That is the end of the session. Thank you.